Hi, my name's Ian Battersby. I'm head of the internal medicine department at Davies Veterinary Specialists. As you can see at the moment, I'm at home rather than in the clinic, no doubt like quite a few of you at the moment, as we adapt to the measures that have been put in place for the COVID crisis and completely appropriate measures as well. Firstly, I want to say that I hope that none of you who are watching or listening have been directly affected by a colleague or family member contracting the COVID infection and requiring hospitalisation. If they have, our thoughts are with them and we wish them a very quick recovery. And in addition, it goes without saying that there are some fantastic people out there at the moment in those key worker positions, particularly the NHS staff, and the doctors, the nurses, and all the cleaners and the support staff running those hospitals, and those working in social care situations and supermarkets and things like that are doing a fantastic job supporting us, and we want to obviously say thank you to them. Now, our practice is adopting to the measures that we quickly adopted the social distancing measures and switched to emergencies only and urgent cases only. And we're managing those with a combination of remote consults and social distancing policies. And we are offering some remote consults for more chronic patients where we can do, hopefully offer some advice until this to owners who want to be referred for chronic cases whilst this crisis abates. But as a consequence of that, we're finding we've got a little bit more free time. So we've been coming up with different ideas to try and, provide information for you guys and hopefully make that as interactive as possible. So we do the webinars and we do the Davies Out of Hours podcasts, and we thought we'd just expand a little bit on these question and answers sessions. So what we did a couple of days ago is that we submitted we just put out on social media a request for questions to internal medicine, any topics that you want to know a little bit more about, so that we can share those answers to as many people as possible. And thank you to everybody who submitted those questions. We've got a few to talk through today, and we've also got enough to already build on for another podcast next week, which is fantastic. So keep them coming in. There's a few headings to talk through just today. The first one was immune-mediated hemolytic anemia, and it wasn't regarding immunosuppression. It was more focusing on the therapy that we put alongside that. So the gastric protectants and also thromboembolism prophylaxis. So before I forget, there are a couple of, if you want to know a little bit more about IMHA in more detail, and we've got a couple of things to highlight. Firstly, there's an ACVM consensus that came out beginning of last year sometime that covers immunotherapy and all these kind of therapies in a more detailed manner with a literature review as well. And Polly Froud at the moment is just putting the finishing touches. Polly Froud, a member of the medicine team here at Davies, is putting the finishing touches to a more in-depth webinar that we'll be recording shortly. So if we just deal with the thromboembolism prophylaxis first, that's a little bit more detailed. So if you look at the types of clots that tend to form in these cases, they are predominantly in the venous system. Now, because of the lower shearing forces in the venous system, those clots tend to be more fibrin based. So it would seem logical to target therapy that would reduce fibrin production. And when we think about the drugs that we can use in that scenario, we've got two broad groups. We've got the medications that are antiplatelet, so reduce those platelet adherence, and then we've got the anticoagulants that interfere with the which act, rather than interfere, on the clotting cascade, and as a consequence, affect the body's ability to produce fibrin. Now, so it would seem more logical then that an anticoagulant would be the first day of therapy. Now, having said that, there is evidence that using antiplatelet medication is advantageous. Some of the studies in the veterinary literature have the usual limitations, so not as strong an evidence. In human literature, you know, in IMHA, they do show that there is a benefit from using an antiplatelet medication. So as a standard, certainly all of the team at Davies use clopidogrel as first line in these cases alongside immunotherapy. And if that's not available, then they'll use aspirin. Now, the anticoagulant aspect is a little bit more complicated, certainly from my perspective anyway. Certainly there's arguments to use it because of the fibrin nature of the clots, but using anticoagulant therapy, you need a lot more tighter monitoring, and there's more care required. So if you think about the medications that we can use, traditionally it's going to be heparins or low molecular weight heparins. I'm not going to pronounce any of those low molecular weight heparins. I struggle with it, and we're doing this in one take, and I'll probably have to re-record it about 50 times if I then even not get close. But when you're using heparins, and particularly low molecular weight heparins, you need close monitoring to make sure that your dosage is appropriate. Now, optimally, that is done by measuring anti-factor 10 levels. And the difficulty with that is that that is an assay that's not readily available for most of the veterinary profession. And the reason why we need to monitor anti-factor 10 or clotting factors is that there are studies showing that there is variable pharmacokinetics between individual animals for individual doses of heparins. So one dose may be too much. One dose may be, the same dose in another animal may be optimal, and the other dose may not even reach a therapeutic level, or even might, because it's subtherapeutic, create more issues with the clotting cascade. So, without that assay available, you're already kind of opening yourself a little bit to the variable metabolism of those medications. In addition, certainly with the low molecular weight heparins, I find it quite challenging to dose some of these patients accurately because it's such a small volume. And then you've got to ask an owner to do that regularly. And again, if we're talking small differences make a big difference to the dose, that can have big consequences. So, my own personal view is I started using low molecular weight heparins in these cases, but for a variety of reasons, I don't anymore. Some of the team do. And I guess what they do instead is that they use coagulation profiles, the traditional ones, APTT and PT, but they're not going to be as sensitive as the anti-factor 10. However, there is a newer medication that offers a potential alternative, and this is a medication called rivaroxaban. So this is an oral medication that you use that has anti-10 activity. Now, I've been off the clinics with concussion for about 6 months, so I haven't had an opportunity to use this medication, but some of the team are now using it in addition to antiplatelet medication. So they're using the immunosuppression, then they're using clopidogrel, and then they're using this drug as well. So if you'd like more information about that, please feel free to give the medicine team a call and we can offer advice. Second part of the IMHA question, almost forgot about it, was the gastric protectants. Now, many moons ago, a lot longer than what I care to admit, well, right, is it about 20 years now? I was doing my residency. Pretty much every case that came in that had high doses of steroids for their IMHA would go on to, before I forget, I forgot to mention one thing on the IMHA. Obviously, if you've got an Evans syndrome, so this is where the immune-mediated hemolytic anemia and immune-mediated thrombocytopenia in the same case, you obviously don't want to consider antiplatelet or anticoagulant therapy until those levels are back up. Sorry, diverged then. So coming back to gastric protectants, I was saying, traditionally I was taught to use gastric protectants in all of these cases because of the risk factors. As with all things, medicine recommendations evolve and change, and certainly this isn't something I do as standard practice now, and certainly that is mirrored in the consensus statements. I only do it if I know the patient's got an ulcer, or I know that it's got a definite risk factor that would make it more likely to develop an ulcer. If I am going to use gastric protectants, I don't use H2 antagonists. I'll use proton pump inhibitors, and there's evidence that is showing that that certainly proton pump inhibitors have a significantly better effect in elevating the gastric pH when compared to the likes of ranitidine and things like that. Having said that, I suppose we should make a comment about the current climate. We've benefited greatly by having blood units on hand, that we can do blood transfusions, a lot easier than 20 years ago, even when I was training as a resident. So a lot of our patients now are being managed with a higher number of units of blood. They, as a consequence, are having a higher PCV during their management, and that is a risk factor that's been removed. However, with the current COVID situation and social distancing, I know that the PED blood bank are looking at measures to continue collecting in a socially distant, responsible manner, but we may have to accept that our blood store, the luxury that we had with that, that we got of those blood stores. Luxury is probably not the right word, but you know what I mean. That kind of reliance that we'd had is no longer there, and some of these patients may have to be managed with PCVs lower than what we would normally, and then that would be a hypoxia risk with respect to particularly if the steroids are involved as well. So certainly if you manage them with lower PCV, I'll be starting to use gastric protectants more. So I hope that makes sense. And like I say, if you want more detail on IMHA, there are those ACBM resources, but also there's the webinar that will be coming out shortly. And if you want to be alerted for when that's going to be released, or any other of our webinars, please email our marketing team. We'll insert a little email address so that they can keep your details on file for GDPR reasons. We can then email the details that the CPD is coming out. So moving on to the next topic, a few questions about protein losing nephropathies, which we do get quite a few advice calls about, and the frequency of monitoring. Generally speaking, we tend to leave it at least a couple of weeks after a dose adjustment of your ACE inhibitor, for example, in these protein losing nephropathies before reassessing the UPC. One thing that's quite key, though, is that you make sure that your way of sampling for the urine is consistent as well. So this is referring to a study that was done probably about 4 or 5 years ago. I mean, admittedly, it was only a small study with about 25 dogs looking at urine samples that were collected in the home environment and then urine samples that were taken in the clinic. Now, they found no difference in UPC numbers or values in patients, depending, based on the way they sampled it. So comparing free catch and cystocentesis. But and they found no in a patient that had a UPC below 0.5. Again, they found no difference between the hospitalized and the at-home sample. Where they did find a difference was in 50% of the dogs that had a UPC over 0.5, there was a significant change. So these are patients where the UPC is abnormal, and in half of those dogs, they found an increase in the UPC in the hospitalized sample when compared to the home one. In one case, I think it was almost double. Now, if you're using these samples to make treatment judgments on your therapeutic monitoring and treatment decisions, you don't want that factor playing a role, because obviously you could, if you took a sample at home and then the next time took it in the hospital, that could make a big influence on your decision as to increasing your drug therapy. So again, it's always important to make sure with a UPC that the way you sample is consistent when you're monitoring. The next topic was an area that both myself and Julian Bazell find very interesting. It's the microbiome, probiotics and fecal matter transplants. The more you learn about the microbiome and its integral involvement in our health and the way we not just in the way we digest food, but the way that we those bacteria interact with the gut immune system, the more we realize that we're just scratching the surface, and this is actually a really complex science area. And if you just think about IBD. IBD is a blanket term, no doubt, for a large number of dogs and cats with multiple different etiologies, all grouped under one heading. I mean, we see a lot of patients that are dietary responsive. Is that a true diet response, or is that the diet manipulating the microbiome? We talk about, we've got these antibiotic responsive cases interacting with the microbiome. So fecal matter transplants and the use of probiotics is a way that we can potentially reduce the antibiotic usage in these cases, and hopefully manage them more successfully as well. And if some of you may know, a particular interest of mine is antibiotic stewardship, and so anything that we can do to evaluate more closely, where we can reduce the use of chronic antibiotic in these cases, is a good thing. So in the fecal matter transplants, I don't consider it a first-line treatment. For me, it's a patient that's failed the traditional kind of approach to for a chronic enteropathy. The reason why I don't see it as a first-line treatment is that when you might think it's a bit of an odd thing to think about. You're moving bacteria from one healthy patient with no GI history into the bowel of a patient with a chronic enteropathy. Now, you're not just moving, I mean, there's millions and millions of bacteria that we can't culture in the stool. So we're not going to, the good bacteria we can't culture may benefit, but we also may be moving, viruses, protozoa and things like that, or bacteria that patient might not be able to deal with. So that's why I don't use it as a first-line treatment at the moment. In humans, this is an area that's become a massive area of interest. To a point where if you contract Clostridial difficile whilst hospitalised on chronic antibiotic therapy, UK NICE guidelines have fecal matter transplant as one of the options because of the increasing success of that technique in that situation, and obviously the increasing resistance of antibiotics of Clostridial difficile, where they're getting vancomycin resistance. And there's a lot of research into, there's a lot we don't know about this from a veterinary point of view, but there's also a lot we don't know in humans. That it's certainly acknowledged that there are some people who have healthy microbiomes that seem to improve a greater proportion of people. And they're actually termed golden colons, believe it or not. And the screening and monitoring of those patients, they do a lot of health checks to make sure that those people are free from viruses, that their body condition scores are all fine, because they're very conscious that moving the microbiome doesn't just affect your bowel. It might be that those bacteria start to metabolize your food in a different way. You absorb different products, and that affects other degrees of your metabolism. So a really interesting subject once you start tapping into it. A lot of really interesting science. I could go on all day, as you can imagine. But what I'd probably say, if you want to know more about that area, myself and Julian did a Davies Out of Hours podcast that is available on YouTube, discussing this in more detail. If you want to have that in a podcast form, so audio only, again, email our marketing team and they can send you the links to download it so you can listen to it when you're out on a walk. That's what you want to do. We're going to be looking at, there's a lot of studies going on at the moment, and we're going to be looking at this in a lot more detail, hopefully in some of our patients. We're going to embark shortly on a collaborative study with all the Linnaeus referral centres, looking at the efficacy of fecal matter transplants in these chronic enteropathy patients. So keep an eye out for us recruiting cases for that, but also keep an eye out for when we start to find conclusions and findings. Next topic was, if I have a look, it was Leishmania and mycobacteria. So Leishmania, no doubt, coming to prominent because of all the dogs that are moving across Europe, particularly Southern Europe. And of course, we have these rescue dogs that come from Eastern Europe or other parts of Southern Europe that may or may not had adequate screening and then come into the country and subsequently develop Leishmania. Mycobacteria, a prevalent subject at the moment because of the, no doubt because of the links between mycobacteria cases in cats and the feeding of raw venison meat. Both of those topics are great topics to explore in more detail, the treatment and the testing. Patricia Ibarola, a member of the medicine team, actually does a lot of lecturing on this topic, in particular Leishmania. So what we thought is that rather than me doing a brief summary now, we'd record a podcast in the next week or two to put out for you guys. And similarly on mycobacteria, Catherine Clark, my resident, she's just entering her 3rd year now. She did a presentation on mycobacteria in a lot more detail, in particular some of the new testing techniques that are available. I missed it because of my concussion, so we thought it would be a good opportunity for me to have a chat with her about what she found and what her presentation, and her research, concluded. And again, we thought we'd do a podcast so that we can put that out there for you guys and sharing that knowledge. The final topic was just referring up to, it's not a common scenario that you end up in, but looking at the decision making on when to do a DDAVP trial or a modified water deprivation test. Now, if you know, I'm saying modified water deprivation test because I would never do a sudden water deprivation. The water deprivation test that I do is a gradual reduction in water intake over 4 or 5 days. Now, it goes without saying that is quite a labour-intensive, involved thing to do. Patients need to be catheterised so that you can obtain urine samples, particularly at the end of the full deprivation. You need to weigh them regularly, and you need to check regular electrolytes and things like that. So it's an involved thing, whereas the DDAVP trial, is a therapeutic trial based on clinical suspicion. Now, this is a kind of scenario where you probably line up 100 internists and you probably find, a lot, one group that have one preference, one that would have another preference, and then a lot of people in between, depending on the scenario. I've certainly used DDAVP trials in a small number of cases. Some of them have been successful, and that's where I've had a high clinical suspicion. Some of them haven't, and it's kind of muddied the waters. But I've made the decision in those scenarios for either financial reasons or temperament reason. The patient's just not suitable to be hospitalised that closely, that I've adopted that. I have been referred cases that have had an inconclusive DDAVP trial that have partially responded due to another underlying condition. And certainly I'd only do the DDAVP trial if I'm happy that I've excluded everything else. You might be gathering from the way I'm talking, it might be old-fashioned and it's more labour-intensive, but my preference is to adopt the modified water deprivation test as much as possible, because I think that you're more likely to get a robust, interpretable result. It's not a perfect test, by all means, but certainly in my experience, it gives less inconclusive results than the DDAVP trial. But like I say, line up 100 medics and you'll probably find a slightly different interpretation on that. So I hope that's been of use and of interest. Like I say, please continue to submit your questions for medicine. If you've got questions about needing advice for a case, please feel free to contact the team. We've still got clinical teams working on the floor at the moment that can provide advice for cases. But if there's any topics or subjects or particular drug-related therapies that you want to know a little bit more about, please submit them, and then we can include them in the next version of this internal medicine podcast. Keep a lookout for our webinars and our Davies Out of Hours podcast that will be coming out hopefully over the next couple of weeks, that we'll record shortly. And finally, and most importantly, stay safe.